welcome to In the Margins. Today, I am excited to have as my guest Dr. Alonzo Plough, who is Vice President for Research, Evaluation, and Learning, and he's also Chief Science Officer for the Robert Wood Johnson Foundation. Alonzo, welcome to In the Margins. Also pleased to welcome Dr. Thomas LaVeist, who is Dean of the School of Public Health and Tropical Medicine at Tulane University. And he's also the new chair-elect of the Association of Schools and Programs of Public Health. Dr. LaVeist, welcome to In the Margins. Thank you both for taking some time out of what I know is a busy schedule to be with us. And I'm just excited about the conversation that we are about to have. And I will actually start with Dr. LaVeist. Dr. LaVeist, I was wondering if you could talk about your background and when you first became interested in researching health inequities. When did this whole research field looking at health inequities come to your radar? How did that develop in your professional career?
Today, and that question, I think my personal experience, I think, aligns with really what happened nationally in the health equity space. So I was a PhD student working on a dissertation, working on a degree in demography, and I was going to be focusing on political issues and trying to understand I was doing a dissertation on Black political empowerment and the impact that Black political empowerment in the 1970s and 80s had on African Americans in general. And as I started looking for ways of measuring quality of life for a population, I kept coming up with these health measures. I kept finding these health measures and became really interested in it. And one day, while frankly procrastinating about not writing my dissertation, I stopped over in a used bookstore and was thumbing through a book and came across a book about the Titanic, of all things, which may be more a reflection of my state of mind at the moment, that I'd be attracted to a book about the Titanic. But I start going through this book and I find this page where they're talking about survivors on the Titanic. And what it showed was that the class of ticket predicted whether or not you survived. In other words, if you were first class, you survived. If you were third class, only about half of them survived. And that revelation was fascinating to me, that social factors, such as in this case, the ability to purchase a first class ticket, was the determinant of whether or not you survived more so than any other factor. And that's when I really started thinking about the ways in which these social issues, political issues, economic issues can be as important as biological issues in determining the health of populations. And that's where I changed directions and went into public health and left demography.
Oh, that is fascinating.
But I want to add one more thing and I should say that was right around the same time that the Department of Health and Human Services published a report called the Report of the Secretary's Task Force on Black and Minority Health. And that report, that 13-volume report, just laid out the breadth of this problem. And when I came across that report, that just really solidified it for me that this was going to be the thing that I was going to focus my career on.
Dr. Plough, I have a similar question for you. I was wondering if you could talk a little bit about what initially attracted you to public health. Because, of course, looking at your bio, I see that you've worked for government and municipalities. And what ultimately brought you to the Robert Wood Johnson Foundation? I was wondering if you could talk about your journey a little bit, Dr. Plough.
Okay, it's a long journey. It was a long journey, but it actually goes back. When I was actually a child, I had a relative, cousin of my father's, who was a public health visiting nurse in our community in Kansas City. And Aunt Lucille had interesting stories to tell about the work she was doing and the families she was working with. And, this is a time when she was trying, like everybody was trying, to get people to take the then new polio vaccine. And that was interesting. That seemed interesting to me, and for some reason was stuck in my mind somewhere. Kind of, and then I had activist parents, so doing something socially activist was ingrained. And so I had an opportunity when I finished all my graduate school and was an academic. I had an opportunity to I mean, had a public health degree, but I hadn't done public health practice. I had an opportunity first to start working with a community group in Boston who was a consortium of Black health center directors around Black infant mortality, and providing the kind of academic support to their activism. That got me first in trouble with the mayor of Boston, but later an invitation to, I won't use the exact salty language that mayor used, but he essentially said I could come inside and work with them rather than being outside and being a nuisance with my colleagues. So I took a sabbatical to run the Boston Health Department, and found that public health practice was more exciting to me than just being an academic, though I've done both. I've continued to do both. But that's kind of what got me into public health practice: Boston, Seattle, Los Angeles. And I think that kind of diverse academic and public health practice experience, all of it focused on what we now call health equity, kind of what got me to the Robert Wood Johnson Foundation, who was, I think it's fair to say, Thomas, was about to turn the corner from pretty conventional to this broader notion of building a culture of public health and equity. And that was exciting enough to get me out of the West Coast and off the beach and into Princeton, New Jersey.
Dr. LaVeist, it's interesting that you use the Titanic analogy, looking at how that great event affected different classes of people, literally. And of course, that echoes straight to COVID-19, as you, of course, both know and have seen, as is typically the case. I don't know what comes to mind. What comes to mind is the whole analogy of, they say, when, all people, let's say the majority population catches a cold, marginalized populations catch pneumonia, right? It always is exacerbated. And the numbers for COVID just illustrated, this particular problem. Looking at death rates, if you compare the majority population to minority populations, alarming disparities, but this is nothing new. And so I was wondering, Dr. LaVeist, if you could talk about, from your vantage point, what COVID revealed with regards to some of the wide and alarming disparities that you have researched. So I was wondering if you talk a little bit about some takeaways you had looking at the numbers and your experience observing what happened in around this pandemic.
Yeah, interesting question. So I also served as the co-chair of the Louisiana Governor's Task Force on COVID and Health Equity. So I was very much steeped in this issue. It revealed many things. So it revealed, first of all, that the public health system in this country is as fragmented as the healthcare system in this country. And the fact that there isn't coordination between the various levels of government, I think, was one of the reasons why we had as many deaths in this country. I think it also revealed the degree to which social factors are the drivers of the disparities as opposed to biological factors. Because when you look at geography, the United States is a dramatically racially segregated country. And because of racial segregation, when you have an infectious disease that is spread in part by physical proximity, and people are segregated in communities, you find that they're going to infect people that they have the greatest proximity to, which was going to be people of their own racial and ethnic group, which is why that virus circulated so much in the African American community, in the Hispanic community, and in the Native American community. So it reveals the way that the structure of the country, the way that we've organized the society, puts people at risk, at various levels of risk. New Orleans was one of the early cities that had a huge outbreak, along with New York. We believe that the outbreak in New Orleans occurred during Mardi Gras, and visitors from other parts of the world could come to New Orleans. engage with people working in hospitality who were disproportionately people of color, African Americans. They then went home to their communities, and that's where we saw the spread. And the early maps that we created for the city of New Orleans show that the death occurred almost exclusively in census tracts that were predominantly African American. And by predominantly, I mean 95%, 90% or more African American. That's where those deaths were occurring. And the spread was happening in those communities. And so it demonstrated the degree to which social factors was the driver, the thing that facilitated the distribution of this disease. You also look at economic issues. Who were the people that had a job that allowed them to go home and watch Netflix and have people bring food to them through Uber Eats? And who were the people that were working for Uber Eats and could not stay home and just watch Netflix and still get paid their jobs? Again, we see that disparity in employment playing out in health, and as a result of the fact that people are in more vulnerable positions because of jobs that they have. You also saw that we have multi-generational families disproportionately in the Black community and the Hispanic community as well. And so you have families where people are living together in the same house of multiple generations. There may only be one person in that household that's working, and that one person comes home with the virus and spreads it to older people who are living in the house, and then we saw a lot of deaths occur that way. So I think it demonstrated the way that racial segregation facilitates ill health. It demonstrates the way that employment status and the types of jobs people have put them at different levels of risk, and how the social and political determinants are the drivers of the racial disparities.
Yeah, Dr. Plough, curious if you could also talk just a little bit about how COVID, from your perspective, revealed so many of these health inequities that we are discussing today.
I'll just expand on what Dr. LaVeist already said. I mean, it showed and it amplified the persisting inequalities based on race and a lot of other marginalizing factors. So when a pandemic comes through in that context, then those who are always marginalized become more so and have a disease incidence and prevalence higher than others. So, and it pointed out, I think, for those of us in public health, the real weak spots in our public health system, the real weak spots in our ability to connect with other systems. People were dying in nursing homes. We don't have data that connects very well to them. People were dying in the criminal justice system, isolated. We don't have information systems or connectivity to them that well in our public health and healthcare systems. So a major lesson of COVID was, I think, as Thomas said, we knew that these social, economic, and marginalizing factors were creating unfair life opportunities and chances. COVID put it in bold relief. And I think for all of us who've been working in this field, I think it caused us to double down, and maybe we got a few more allies to think about it, because there was more awareness of this inequity given the scale of its impact in COVID. I had wished the lessons were had a little longer half-life than they have had, because I think we too quickly forget the underlying drivers of inequity that led to that inequity in COVID. We still have a lot of work to do, and let's just work on this morning on the misinformation and disinformation targeted at communities of color during the COVID outbreak, which continues to be something that amplifies marginality and unfair health outcomes. So it should have been more than a teaching moment. It should have been like a teaching era. But I have hope. But we're at Foundation. We're working to make sure that those lessons continue to shape the work and the kind of influence we're trying to have on building a more equitable health and healthcare system.
Yeah, and Dr. Plough, I was wondering if you could now talk about the genesis of the Transforming Academia for Equity program. I was wondering if you could explain for our audience how this program came to be, your involvement in it, and what are the goals for TAE? I was wondering if you could talk a little bit about that.
Well, that's a great question. That started a little bit before COVID, but it came from my experience as a long-term public health faculty member. I think about 4 different schools over the years. That if we were going to, as a field, and I'm sure Dr. Levies has a lot to say about this as the incoming chair of the association. But if we as a field were going to rise to that challenge, we had to inspect our practice, our training, the ways we were thinking about how we train our researchers, the way that we need in schools of public health to connect more dynamically with the communities in which we all sit. Virtually every school, I think every school of public health that I was on the faculty sits in the middle of a neighborhood experiencing extreme health disparities, but never had the kind of interaction with that community, partnership with those communities, where they were considering themselves of it and not some sort of academic extraction alongside of it. So we really felt like an opportunity to get a cohort of schools together in collaboration with the broader association to see who could be some folks to innovate around transforming some of our assumptions about what it means to be an effective researcher and public health practitioner to address inequity. It's EDI, but it's more than EDI. It has to challenge what we think is usable knowledge, why we keep all of our good knowledge in academic journals that Thomas and I read, but not a lot of our partners who we need to work with is inaccessible to them. So how do we make our practice more collaborative, open, action-oriented, and just augmented by other kinds of rigor than those more traditionally academic kind of narrow things that we do. We're not advocating getting rid of that, but we're advocating something broader, particularly around being able to more effectively address health inequity, structural factors like racism in our practice.
Dr. LaVeist, I was wondering if you can talk about your involvement with transforming academia for equity. Your perspective on this program's potential for ultimately helping to close some of these health equity gaps that we are seeing. And furthermore, coming in as, of course, the new chair-elect of the Association of Schools and Programs of Public Health, I was wondering if you talk about how you will maybe able to use this platform to be able to move the needle and closing these health inequities that we're discussing today.
Yeah, thanks for that question. I mean, the Transforming Public Health for Equity is a critically important program. There's only a small number of public health schools that are officially a part of the program, but I can assure you that all of the other schools are watching very closely to see what happens and for lessons learned that we can, bring into our schools. So we have an awesome responsibility, that is to educate the public health workforce of the future. There'll be that group of workers will be working in an uncertain future, and we don't know what that future is, and we need to educate them to be able to adjust to what is going to be coming at them. It's a very complicated thing to do, which is why we're all watching so closely. Transforming academia is critical because there's a lot about academia that I think we have not been as effective as we can be at impacting community health, in part because of the way that we are structured. For example, we create a lot of valuable knowledge, and as Dr. Plough alluded to earlier, that knowledge is locked away in the library and only accessible to people who have access to that library and have been trained to be able to read those journal articles. The people who are the consumers of public health work are disproportionately Black and brown people, but the people that are creating that new knowledge are disproportionately not Black and brown people. Now, that's not necessarily an indication of in and of itself as a problem, but it is a problem because we need people who understand in a nuanced way the aspects of these cultures and communities that we need to work in if we're going to move the needle in improving the health of this population. So we need more people who are coming from those communities who have sort of this kind of endemic understanding of the nuances of how things operate in those communities so that they can create interventions that are going to be more effective. We're all watching very closely to see what this program comes out with and how we can implement that into our schools. In my role as board chair, next year, the accrediting body for the Schools of Public Health, which is SEEF, is going to be revising their accreditation standards. And when that accreditation revision goes through, I will be chair of the association at that time, where we work very closely with the accrediting body. And we're working on embedding into the accreditation standards competencies that relate to health equity. And some of that is is going to be based on what we're learning in this program. So there's an opportunity to embed into the accreditation standards for all schools of public health some of the learnings from this program, which is why it was so critical and important to me to run for board chair for that year in particular, so that I can be there. That was the way that I'm hoping to use my position. The other thing that I'm working on is that we've established, we meaning the Tulane School of Public Health, we established several schools of public health in Africa. The first one as long as 40 years ago in the Democratic Republic of Congo. And I was recently there, and also at the University of Rwanda, where we established a school there 20 years ago. And I'm now working with the association and also the accrediting body for public health schools to establish a category for these African schools, with the goal of helping those schools to progress to the point where they will be ready to be fully accredited schools of public health in Africa. And I think in that connection between Africa and an African American community is a part of what we're working on, looking at how we can bring the diaspora together. And again, the point is to try to embed this into accreditation and embed it into the curriculums at the schools of public health, so that we move away from a scenario where we currently are, where the consumers of the work we do are disproportionately Black and brown, but the producers of the knowledge that we rely on are not Black and brown, and the workers that are doing the work also will be a better reflection of the community.
Dr. Plough, of course, what we're seeing nationally is anti DEI push. We're seeing that in the political realm and other realms, those who say we need not focus on diversity and equity issues. And some of that, of course, is seen in the education of public health practitioners and medical practitioners of all different kinds. Some will say, if I'm in medical school, why do I need to take a cultural sensitivity class, right? This is a science, right? We are dealing with blood counts and empirical data, or if you're doing an MPH or something else, that there are some who say that it is unnecessary to focus on cultural sensitivity and understanding the needs of diverse populations when dealing with something that some will say is very straightforward when it comes to healthcare. And so I was wondering, Dr. Plough, if you could talk about the importance from your perspective in engaging with academia and some of the challenges that you are finding as you embark on this journey.
This is a serious issue. One of the communication beats I work for the foundation, and as Fellows knows, is I talk to a lot of schools of public health and a lot of faculty members about what we do, but also to discover the challenges they're having. And I can say for every state-funded school of public health that I've engaged with recently, I will not mention states or schools, but I will say as of just last week, they are all having a challenge, not just with basic DEI, but the teaching of that race is a marginal factor, essentially social determinants of health as part of a curriculum and part of a framing. There's pushback against that from legislatures in some of these states. So it is kind of an attack both on the necessity of EDI, cultural competency, to echo what Thomas said, helping to develop a workforce that's more in sync with the people that the field actually serves. It is, I wouldn't use this word loosely, but there's an assault against those very important and actually, as I'm an epidemiologist, evidence-based approaches to improving health and well-being in these communities. It is forcing certain schools, and what I'm enthusiastic about is from my visit last week with one of these schools, how they are very cleverly working with wording and the way that they present these issues so they can get the work done without it being flagged by legislative bodies that are looking for certain flagged words, looking for certain words. But that's a lot of work to put on top of the real work, which is to address these inequities. So it is just making even more difficult to do the work when you have to do the kind of code shifting and all of that and the rearticulation to do the work, which is what I've seen our colleagues doing, particularly in the schools that have that kind of state level oversight. And again, I will not mention the schools, but I was asked to be on a very cutting edge advisory committee around improving EDI and research approaches to address structural racism. That committee had to be renamed. The dean of that school was told that committee had to be renamed. You know, those are serious problems. I don't want to underestimate how much of a challenge that is going to be. Thomas is at a private university, you know, and there's a different context there, and we're working really hard to support those schools. We do a lot of work on some of the communication approaches that could get around some of these issues by some of the grants that we fund and some of the communication firms we're working with, to where I think you can use language that doesn't take away from the urgency and the cutting edge of what you need to do, but you can at least keep a foothold in doing the work in environments where certain words are trigger words. But again, public health practice has been difficult enough without having to do that on top of it.
Yeah, Dr. LaVeist, I was wondering if you could also weigh in on the particular challenge that so many of the institutions that you, of course, are working with are facing, given the political headwinds of this anti-DEI push that's seen across the board. I was wondering if you have any thoughts about how the community can respond to that challenge, the public health community.
Yeah, well, as Dr. Plough pointed out, I'm at a private university, so we haven't had as much of a challenge as some of my colleagues at public universities. But we're not without our challenges. We are in Louisiana, and we've had proposals from the state legislature that for some of the bills that have passed in other states. Our governor has vetoed those bills, so we haven't really had those challenges as we have in some other states. But we have had bills enter that specifically they're not specifically saying Tulane University, but they're describing it. They're saying any organization of this size with this size of a research portfolio, you know, must do certain things, you know, so we're the only organization in the state that met that criteria. So they've been doing things like that to try to impact us, but none of those have passed just yet. But what I would say from a higher education perspective is that the cohort of students that will enter the 9th grade this year is more than 50% comprised of people that we currently refer to as racial and ethnic minorities, okay? In a mere 4 years, they will be the freshman class in college, okay? So what's coming for higher education is a way of diversity in the student body. Whether we are intentional about attracting that diversity into our universities or not, the force of population is powerful, and that is what's coming. What's also coming, and is actually frankly here, and this by virtue of this very conversation, is that those of us in prior generations that were part of the cutting edge of just work on health equity are moving into positions of leadership. People such as Dr. Plough, people like me, who are now in positions where we have opportunities to set policy in higher education. If we continue, and this is one of the things that I try to focus on a lot, building more leaders, making sure that we can build diverse leaders so that future generations will have even more people at the table making decisions. I think that is the way that we need to respond to this. And we have the immediate response, which is the kinds of things Dr. Plough was talking about, how we can find ways to get around these attempts to block these efforts that we're doing. And we have to do that. We should be sharing strategies, and we should be trying to do as much as possible. But we should be thinking about the future, this potential future, the potential of a leadership that is with people who are coming from these communities, who have like again that nuanced understanding of the communities, who put when they are in a position where they are able to actually direct resources, have the sensibility, the understanding of the power that they have, and will use that power to allocate resources in ways that will improve the conditions in communities that have these health inequities.
Dr. Plough, my last question for you. It was already mentioned that there are not tremendous number of schools that are actually part of transforming academia for equity officially. But I was wondering if you might have a word for the institutions represented among our listeners today as to why they should engage with this program and how engaging with this program could help to close some of these health inequities that we're talking about. Why should more schools join this effort, Dr. Plough?
Well, I'm going to do something my comms people don't like me to do, but we will be funding another cohort. I think it's important, given your listeners, to know that we're committed to this. And those 7 schools are really important. But as Thomas knows, this was intended to be 7 schools in collaboration with the association. Yeah. So it was always a leveraging kind of opportunity. And we will develop another cohort in next year. I would also say there's another program that actually we work on jointly with Tulane's Partners for Advancing Health Equity as well, and that's Health Equity Scholars for Action. That this is to Thomas's point about this is a cohort of young leaders, young academic leaders from marginalized backgrounds, where we are providing research funding and mentoring, much of that mentoring being managed through Partners for Advancing Health Equity and at Tulane, to strengthen their leadership, to really give a supercharge their leadership so they can be that next cohort. And Thomas mentioned some of us are now in leadership positions, but we will eventually age out, and we will need to make sure that we are bringing along that next cohort of leaders. So we're doing that. We're going to continue to do this work with the transforming academic environment and in schools of public health. And I don't want to name specifically the next health profession sector that we're going to do this with, because I really will get in trouble with folks. But we are going to try the same approach with another school of health profession education and a cohort to try to do the same kind of thing in other parts of higher ed around health professional training, all around the same issues that we've been talking about, strengthening their approach to have faculty that are representative of the populations that experience the problems we are trying to solve, and developing the new generation of research methodologies and approaches that are more community collaborative and really equity focused. So we are committed to that for the long run as part of one of our major strategies in the foundation.
Dr. LaVeist, we talked a little earlier in this particular podcast reporting about misinformation, right? The misinformation that has spread through minority communities, and misinformation, some would say, with regards to the importance of looking at these social determinant factors when training healthcare practitioners. Some will say, hey, this is not that important, and we have that from the political sphere on down. Dr. LaVeist, I was wondering if you could say a final word to some of our listeners as to the importance of partnering with yourself and others who are vested in training the next generation of leaders, of practitioners who are committed to closing these health equity gaps. Any word for those who may be skeptical of this work that you're doing?
Well, I want to thank you for that question because it perfectly tees up my opportunity to talk about Partners for Advancing Health Equity, right, which is a program that is funded by the Robert Johnson Foundation. And what we do is we're bringing together people and organizations that are coming from multiple sectors of society to try to build more synergy across people that are across the organizations and people that are trying to make a difference in this health equity space. So we're working with organizations in academia, in government, community-based organizations, private sector, and philanthropy to bring everyone together. So all of these sectors have efforts underway of some form to address health equity. But none of us independently have the ability or are big enough or powerful enough to really move the needle. But the idea is that if people can get on the same page, if people can be more synergistic, we can build collaborations across sectors and across organizations, then we can leverage each other and have a bigger impact. That is why, I mean, I think that's the potential. Partners for Advancing Health Equity is a membership organization. It is absolutely free to join. All you have to do is say, I want to be a member, and you go to the website and you sign up, and you get invited to all of our activities and learnings and the opportunity to become a part of shaping what we do going forward, because it's a member-driven organization, and the members basically help us to determine what the agenda will be for the organization.
Dr. Plough, Dr. LaVeist, I thank you so much for your time and for engaging with us here at In the Margins on these very, very important topics. Thank you so much for joining me. Appreciate the work that you do. Thank you so much.